Good morning, everyone. Today I'll be discussing about the topic pit and fissure sealant. Various procedure, various step, indication and contraindication, primary level of prevention in dentistry, and how it is important pit and fissure sealant in dentistry we'll discuss in this topic. Pit and fissure. Pit is defined as a pinpoint depression located at the junction of developmental groove or at terminal of those groove, and fissure is defined as a deep cleft between adjoining cusps. Pit is mostly a point angle and fissure is a line angle. In pit and how pit and fissure is different from restoration, as in pit and fissure, we don't try to cover the normal anomaly of tooth. We just put the excess material in the pit and fissure area so that the chances of the caries does not take place. Pit and fissure sealant. The term pit and fissure sealant is used to describe a material that is introduced into the occlusal pit and fissure, a caries susceptibility teeth, thus forming a micromechanical bonded protective layer cutting excess of caries and producing bacteria from their source of nutrient. So, as we are talking about nutrient, some amount of nutrient are present in the pit and fissure sealant in the form of sucrose. So once that area is sealed off, so then there is a less chance of caries to occur, and thus it is important to use pit and fissure sealant. These are the various different type of pit and fissures which are seen. The most commonly seen is the V type, wide at top and gradually narrowing at base. Then is the U type, that is almost the same width from the top. I type, that is narrow extremely in a form of a narrow slit. And I and K type, that is extremely narrow slit with a large space as bottom and inverted Y-shaped form. While sealant, the fissures and pit are normal anatomical finding in a dentition and caused by fault in dental enamel. Shallow fissure may not be problematic and be self-cleansing and resistant to dental caries. However, deep and narrow fissures tend to lead to tooth decay. Both pit and fissure act as an area of initiation of caries due to food retention. So, to prevent dental caries, it is safe, efficient and effective method of prevention of pit and fissure caries. Sealant not provide, as the incidence of caries is relatively low on the smooth, self-cleansing surface, buccal, lingual, mesial, or distal surface, where fluoride are highly effective in reducing caries. Unfortunately, fluoride is not nearly as effective in the pit and fissure, where approximately 50 to 85% of tooth decay is found. Susceptibility mostly are seen on the occlusal surface, then on the mesial, then buccal and lingual surface. The reason for this, that is high rate of caries rate relates specifically to the pit and fissure morphology of occlusal and buccal and lingual surface. Bacteria are not able to breed in deep narrow fissures where enamel did not completely form, that is called non-collagenous of enamel. In many cases, tooth bristle cannot reach to the depth of these spaces to remove bacteria. There are various classification of pit and fissure that is based on the polymerization method, first generation, second generation based on the resin system, then filler particle, then color. Most commonly the first generation UV light polymerization method is used. Indication of pit and fissure, that is carious occlusal anatomy. If pit or fissures are separated by transverse ridge, a sound pit or fissure may be seen. Carious pit or fissure, that is deep narrow pit and fissure. General caries activity, that is mild, many occlusal lesion, few proximal lesion and recently erupted teeth. What are the contraindication for pit and fissure?
That is, it cannot be done in cases which have a many proximal lesion. General caries activity are very high in sound, broad, well collapsed pit and fissure, teeth without caries, free for 4 years or longer in case of rampant caries or most of the tooth decay. Interproximal lesion, occlusal surface is already carious, tooth present in mouth for many years and there is no evidence of decay. In these cases, we need to avoid the pit and fissure sealing.
Sealant are the most effective clinical technique to prevent pit and fissure caries. The cost effectiveness of sealant naturally is based upon sealant retention. While the rate of sealant retention on occlusal surface are relatively high, at 5 years, sealant retention for buccal and lingual pit and fissure of molar is considerably lower. These are the setups for sealant. And the procedure for sealant is cleaning of tooth, tooth isolation, enamel etching, application of sealant material, curing of sealant material, inspection of sealant, and re-evaluation of sealant. All this step by step we will see further. This is the first step of sealant, that is cleansing of tooth. Use a cup and pumice with water. Any non-fluoride paste can be used. Run Explorer through the grooves to remove pumice. Thoroughly wash, dry and re-examine. Mechanically prepare the tooth and there is no need of anesthesia. Tooth isolation is very important. To maintain a proper isolation, use rubber dam or cotton wool. If the tooth is contaminated with saliva, the etching must be done over again because it will not be effective. After the proper isolation, tooth is etched with 35% of the phosphoric acid in gel form applied on the cuspal area to create a microporosity within the enamel. Etch tooth 20 to 30 seconds and fully rinse and dry the mouth. Remove the caries portion, apply the sealant material according to the manufacturer direction. A brush is used to allow it to follow the curvature of the tooth. The sealant may be light activated or self-curing and avoid air bubbles. Visible light is used to cure the sealant material. Don't touch tip of cure light to the sealant material. Then we need to do the inspection of a sealant, that is a user explorer, to ensure that all grooves are filled, sealed and smooth. Verify that the sealant does not extend over the marginal ridge of the tooth. Check for occlusal interference using articulating paper. If necessary, remove excess of the sealant and no contact point on sealant and there is no need for further polishing. Then we need to re-evaluation of the sealant. Observe the sealant at all future appointment. One may need to reapply the sealant. Reapplication along with fluoride and other preventive measure can provide 100% caries free and restorative free patient. Problem and solution for pit and fissure sealant. Air bubbles may be present between or under the sealant. Sealant should be ground down to expose the air bubble and the bubble should then be filled and repaired. Porosity may develop in the sealant. Reapply the sealant. If this is delayed, decay may form around the edges. Sealant may fall off. Reapply the sealant. Caries, decayed, left under the sealant. There is a contraindication for sealant placement. The sealant should be removed and a filling should be placed. Therefore, for the success of pit and fissure sealant, perfect isolation and maintenance of a dry field are very essential. Thank you for watching this video.